So this is module 2.2 eye pain. HPI, 45-year-old male presents with right eye pain. Pain started after waking up this morning. Patient slept with his contacts in for the past 4 nights. Patient states the pain is sharp, non-radiating, 10 out of 10, associated with tearing, redness, blurriness. Denies any headache, vomiting, recent URIs or upper respiratory infections, or welding. History and review of systems. Past medical history is positive for diabetes. Past surgical history is none. Meds is metformin. Allergies is none. Review of systems. Eye denies photophobia or diplopia. GI denies any vomiting. All others are negative except for the HPI. So key point is visual acuity is the vital sign of the eye. So patients with eye complaints need visual acuities or the eye chart documented always. The nurse should have this in the nursing notes. If not charted, please ask the physician if he or she wants them done. Physical exam vital signs. 92 is the pulse, 160/80 is blood pressure, temp is 37, satting 100% on room air. OD is a Latin abbreviation for right eye. Visual acuity is 20/200. OS is left eye, 20/20. OU is both eyes together, and that's 20/100. This could obviously be documented as an R for the right eye, L for left eye, or B for both. This is just the normal medical Latin abbreviations you may see. General exam patients A and O times 3, anxious, well appearing. HENT is basically where we're going to focus on this physical exam. So OD, again for right eye, the lid, there's no warmth, tenderness, or discharge. Conjunctiva, there's no hemorrhage. There is positive injection or erythema. The corneal exam, there's no abrasion, but there is an ulcer at 4 o'clock. We use the face of a clock in order to demonstrate where on the eye there is actually a lesion, such as an abrasion, laceration, or ulcer. Pupil is 5+ and reactive. 5 numerically measures the size of the pupil, 1 being pinpoint, and 5 to 6 being larger pupils. Reactive means that when we shine light into the eyes, the pupil actually will contract. It's a protective mechanism for the macula or the retina. Extraocular muscles is the movement of the eye. On this patient, they are intact and there's no pain. If there is pain on a physical exam with extraocular movements, there's suspicion of some sort of orbital cellulitis or infection involved in the orbit, or some sort of hemorrhage involving the back of the eye. Fundus is our fundoscopic exam, where we look into the back of the eye on the retina. And in this patient, there's no papilledema, which is just swelling around the optic nerve. So this is a demonstration and diagram of the normal eye anatomy. You can see, starting on the left, the pupil is actually just the entry point through the lens into the back of the eye. It's actually an opening, it's not a structure. The cornea is the surface or the protective layer that sits over the opening, which is the pupil and the lens. The iris is the colored part of the eye. And then you can see the lens, which is the basically a clear, transparent structure that sits behind the pupil. That light that's entering the pupil gets reflected off of onto the back of the eye, which is the retina, the macula. What is not on here is the conjunctiva, which is the thin layer of film that surrounds the sclera, which is the white part of your eye. So in conjunctivitis, the thin layer of film gets infected, overlying your sclera, and that's what turns red and irritated. So a couple different physical exam things that we do with eye pain. A fluorescein exam. First, we will numb the eye, which numbs the surface or the cornea, and then we will proceed to put fluorescein in the eye. This particular fluorescein is orange. There are several different variations, orange being the most common color. After the patient has a fluorescein into their eye, they'll blink a couple times, and then we'll proceed to put a Woods lamp or a black light over the eye so we can demonstrate what's going on. As you see here, a corneal ulcer is demonstrated. So this patient has on their eye exam, that's an injected conjunctiva. There is on exam with a Woods lamp exam, the fluorescein is taken up in the 4 to 5 o'clock area, and an ulcer is shown because there is an uptake of that color fluorescein in that particular area of the eye, or the cornea actually. This is a corneal abrasion, so again, this patient had a fluorescein exam, and the fluorescein is taken up approximately around 8 o'clock on the eye. You see a linear horizontal fluorescein uptake. This is more indicative of a corneal abrasion, as opposed to the previous slide. The ulcer you see was more spherical and more concave because there's actually an ulceration in the cornea, which is that protective layer of the eye. So this abrasion, this patient was scratched with something approximately at 8 o'clock on the eye, and that's where that fluorescein uptake is. This is a demonstration of a slit lamp. This is when we want to do a more in-depth ocular examination, and we're able to better differentiate what's going on behind the cornea in the anterior chamber of the eye, which is the space that occupies between the pupil and the lens and the cornea. So if there's any sort of fluid or anything accumulating, we're able to better visualize that with this magnification of the eyeball. So our differential for this patient, 45-year-old male, we have a corneal ulcer, which we use fluorescein in staining in a slit lamp exam typically. A corneal abrasion, which we can use the fluorescein and the Woods lamp, and we can also use a slit lamp as well. A globe rupture, which is a very bad ocular emergency, and we'll go over Seidel sign, and that can be diagnosed on CAT scan. A corneal laceration, which is typically on exam when we put in the fluorescein. You can see a little bubbling effect, and I'll show a picture of that. Glaucoma, which is an increase of pressure in the eyes. Typically we see this in older and elderly population, and we use tonometry, which is a measurement of the pressures. And then conjunctivitis, which is usually diagnosed just on the physical exam and the history. So this is Seidel's sign, and you see that there has been fluorescein applied, and this is under a black light or Woods lamp. And instead of being a nice spherical type of ulcer or a clean type of linear streaking like an abrasion, you see this kind of oozing. And a Seidel's sign is positive in globe ruptures, where the actual eye is ruptured and the gel-like fluid that consists of the eyeball is starting to ooze out. This is an ocular emergency, and this is when we call it a positive Seidel sign. You can actually see this fluorescein or this dye kind of dripping down the eye as you sit there and watch the uptake of the fluorescein. This is the corneal laceration, so you can see that approximately 4 o'clock there is this linear or curvilinear laceration of the cornea, and you can't really see a lot of the bubbling on this. It's more in real time, but you can typically see a little bubbling. There's partial lacerations and full lacerations, and these are, again, ocular emergencies and need to be taken care of by ophthalmology. So this slide is demonstrating a tonal pen examination. This is for diagnosis of glaucoma. A tonal pen measures the intraocular pressure of the eye. This physician is applying the tonal pen to the right eye. This is done after applying an anesthetic drop to the right eye, and then a normal measurement of intraocular pressure is between 10 and 20. Anything over 20 can be indicative of glaucoma. So in conclusion, there is no labs or radiology needed. The diagnosis in this patient is a corneal ulcer, antibiotic drops, and close follow-up with ophthalmology. And it's very important for a scribe to document the ophthalmological consult and conversation. It's very important to note this conversation also with the patient about follow-up because of ocular injuries and pain. This can result in permanent visual loss. So just key points is make sure that the medical decision-making component of the chart with the physician and the ophthalmologist, and then the physician and the patient, is clearly documented on when to follow up, where to follow up, and that the patient verbally agrees to do this. Just layering the chart that the patient is going to get the close follow-up that they need in order for whatever ocular complaint they're being referred to ophthalmology resolves in a timely fashion and does not go without the proper consultation. So this concludes module 2.2 on eye pain. Thank you.